establishing a cancer genetics program experienced from Nigeria with support from University of Chicago. No disclosure to make. The country is Nigeria. Premier University College Hospital has the hospital, and the University of Ibadan is the university. A common misconception is that cancer is not an African problem. But I know that we are seeing, we have seen, and we can project into what the future holds in terms of reality of what is on the ground. The solution, therefore, is to incorporate genetic understanding and genomic information in cancer care, which requires both infrastructure enhancement with expanded access to research and workforce training, as well as patient and population interventions. Yet, genetic disorders contribute significantly to global disease burden, and advancements in human genetics and genomic research is still leading and will continue to lead to preventive diagnosis and treatment that will chart pathways to personalized care in the continent and the continuum of health and illness. 1 in 8 cases of invasive breast cancer is a result of inherited mutations in BRCA1, BRCA2, PAP2, or TP53. And breast cancer risks associated with these genes are extremely high, according to Zeng et al. 2018. And the $1 million question in all of this is, what's my risk for cancer? People are now demanding and they want to know. That is what's led to the idea of genetic counseling. And the central component is providing information on the possibility of developing a hereditary disease and the risk management options to promote informed decision, according to COA 2014. And the concept we adopted is that was provided by Omand in 2013, that genetic counseling is the process of helping people understand and adapt to the medical, the psychological, familiar implications of genetic contributions to diseases. And in establishing a cancer genetics program at Ibadan, Southwest Nigeria, the process we adapted is KBRN, which we channel this way: knowledge building, KB, R for research, and N for networking. In knowledge building, we began by searching for knowledge. We became very thirsty for knowledge and getting training in the US, and in conducting a study toward capacity building, and then consequent series of training, capacity building, and of course, networking involving stakeholders, change agents, and other institutions. So the search for a mentor began the whole process in 2011, and by 2012, a mentor in the person of Professor Fumi Olopade was found, and access to NIH D43 training grants was provided by her, and the opportunity to shadow genetic counselors in University Chicago Hospital, which dovetail into an opportunity for becoming part of the first cohorts of African Cancer Leadership Initiative recipients of the fellowship. And the relationship continued till it built up into 2014 NIH re-entry grant to conduct a translational research, and that gave birth to genetic counseling and testing projects. There was involvement of the head of Department of Clinical, Public Health and Education, as well as a debriefing meetings with the chief medical directors and the chairman medical advisory committee, which with the endorsement gave rise to team development and team building with various nurse leaders, and 1 or 2 actually having to enjoy the same D43 and re-entry grant that I had the opportunity to have in 2012 and 2013. And by 2015, we had certification on breast examinations of one of our team members, and by 2016, mama care specialist training was also engaged in, and by 2020 and 2021, we had 1, 2, or 3 of us actually went for further training at the City of Hope, and belonging to Community of Practice and Knowledge Building continues. All staff of Funmi Olopade's laboratory and genetic counselors at University of Chicago Hospital partook in this knowledge impartation, and as much as possible, we had interns from Chicago with some of the Nigerian team at various times to exchange ideas and build on the knowledge that is gained. So people became very important. Apart from these 3 steps of the process, which I just explained, we had opportunity also of thinking about 4 key elements. So the process is not just about knowledge building, research, and networking, but also involving people, making conscious attempt to involve people. And so by 2015, there was entry into surgical outpatient clinic, and that's provided a very good footing with involvement of clinical nursing department of the hospital, because the hospital staff is key, whether nursing or medical. And the chief medical director, as well as the chairman, medical advisory committee, and all the heads are change agents that gave all the endorsements that we needed at that point. And by 2016 to 2017, entry into the entire spectrum of the hospital, creating awareness on cancer genetic service, risk assessment, genetic counseling and testing, and exploring perceptions about genetic counseling among breast cancer patients and their relatives. And the strategy continued to 2018 to 2020, where we had opportunity to retrain nurses at the clinics, and genetic testing actually started as surgical outpatient with collaboration with Color, courtesy of our mentor, Dr. Funmi Olopade, like I mentioned earlier. And that gradually extended beyond breast cancer patients to patients with gynecological cancers, ovarian cancers, endometrial cancers, and extended to radiation oncology unit of the hospital, radiology and obstetrics and gynecology clinic, and SOP, standard operating procedures for sample collection, color data entry mechanisms and training for that, and selection of ordering physicians for the hospitals. And then a right time came for survey on patients' willingness to access genetic service and pay for genetic testing. We really wanted to know at this juncture if patients are willing to actually participate in the test, and not just to participate in the test, but to pay. And amazingly, it was supported. And of course, it extended to other institutions where we had training of nurses on genetic counseling and testing, not only in University College Hospital, which is the premier University College Hospital, the John Hopkins of Nigeria, and of course, we extended to Lagos University Teaching Hospital, to Lagos State University Teaching Hospital in 2018. And the training going on is what is shown and displayed here on this particular slide. And this is the diagnostic center at this hospital, where the key officials who participated in the training were here with one of the interns from University of Chicago, Makela. And by 2019, there was yet further extension of the to other institutions. So we have training of nurses on genetic counseling and testing at Lagos University Hospital, as it is as shown here, and another intern from University of Chicago also participated in this set of training, which was at Lagos University Teaching Hospital. And here in 2020, there was a training of nurses on genetic counseling at Federal Medical Center at Abeokuta. In 2021, COVID disrupted the activities, and so there was a virtual training of our Cameroonian team. And then there's a current ongoing plan to extend to another teaching hospital in Southwest Nigeria, which is Obafemi Awolowo University Teaching Hospital, and the plan is ongoing. Like I said, that apart from knowledge building, apart from research, and apart from networking, it became important to break down into these elements of people, which I just finished talking about. And then the next part, element, is technology. So we devised some educational technology in 2014. We had some educational materials which we adapted for University of Chicago. We also had a genetic album that was adapted specifically for patient information and education materials. We developed some flyers for explaining basic concepts of cancer genetics, and we translated the genetic album that was adapted from University of Chicago into local dialects. We went a little bit into some forms of research by finding out and by publishing the findings of the knowledge of genetic counseling among patients with breast cancer and their relatives at a Nigerian teaching hospital. We published that findings in Journal of Global Oncology. And we also did the same with genetic testing for cancer risk assessment in patients with breast and ovarian cancer in Ibadan, Nigeria. Initial findings from genetic counseling and testing projects. And further findings like respondents' perceived benefits of cancer genetics and risk assessment and perceived barriers to cancer genetics and risk assessment. All of these were published. Translating the genetic album in 2015 and validating it in 2018, and by later 2019, genetic testing going on, and then we transited into a new project which is GenCAF, including genetic testing for patients and for at-risk family members, and that is the current project that is going on that is still enabling access for genetic testing of our patients. And this is an excerpt from the genetic educational resource which we call genetic album, and this is what is used in explaining basic tenets to our patients. And this is Yoruba version, which I said we validated. This is the receipt of a consignment of the color kits from the University of Chicago, and this is about 250 in number. And with this, we are able to utilize the 30 gene hereditary cancer panel for the testing of our patients. We have various genes, about 30 in number, including BRCA1, BRCA2, MSH1, PMS2, EpCAM, TP53, P10, STK11, COH, and so on and so forth. And of course, the cancers that are covered are 8 in number, including breast, majorly, ovarian, uterine, colorectal, melanoma, pancreatic, stomach, and prostate. And quality control is written for saliva sample collection, and the video instructions which we usually play is found at this website, at this color site, and we try as much as possible to encourage our trainees to watch, we demonstrate, and they carry out return demonstration before obtaining sample in the real sense. We have training sample kits for training. And in all of this, we have learned to outsmart the politics by good entry, IRB for ethical approval, consent forms at various levels, involvement of key stakeholders at the surgical outpatient clinics, oncology wards, and various units in the hospital, the chief medical director, the chairman medical advisory committee, the nursing chiefs, and other head of departments. And by 2015 to 2017, that awareness creation began. It was easy, and there were a series of capacity building workshops and training. And a very important aspect is actually exploring group approach via multidisciplinary tumor group. That's fantastic. Gave a lot of credence, to the project. And the model that we pattern our activities in this program after is the CDC Cancer Genomics Program Logic Model. It has 4 various strategies, And the first strategy is surveillance. This is bringing about improved data on hereditary cancer burden in trying to utilize cancer genetics services and creating awareness as much as possible. We did that in partnering, in following this particular structure. And then, of course, the strategy 2 was public education and awareness, which is essence of all those education materials. And strategy 3 is provider education, which is all the series of training and retraining. And this fourth strategy is partnership, which is what this mentor, Professor Olopade, with Color Genomics, with Cameroon team, with various institutions in Nigeria. So in all of this, what can we do? We have done a lot, we are still doing, and we continue to do. So we reduce this model to what is manageable for us. And so we have patients and first-degree relatives attend clinics in University College Hospital and other extended centers. We have nurses who have been trained and physicians who are able to take care of all the components. And the first-degree relatives have genetic counseling, verbal consent offered to them, and depends on the pathways. If they are willing to have genetic counseling, they obtain consent and they go ahead and give the counseling. If they are not willing, they get the normal standard care practices in the hospital, and the workflow chart ends there. Whereas on the other side, when they do that, they obtain consent, they take family history, pedigree will be drawn by trained nurses who have been exposed to genetic counseling. And then, of course, if they are interested in genetic testing, another sample, another consent is given. They are consented to be able to obtain sample, and that is the research component of it. And so sample will be shipped to Color Genomics Laboratory for processing and analysis. The results will be sent back to the ordering physician, which we have access to. And then disclosure and post-test counseling will be embarked upon. And it led to various outcomes like dissemination of findings at various fora, including Marrakech, Morocco in 2015, Dakar, Senegal 2016, Kigali in Rwanda in 2017, Chicago, United States in 2018, Maputo, Mozambique in 2019, as well as Bamako, Mali. And 2020, it was the turn of Illinois in Chicago. And 2021, like I mentioned, Cameroon, which pandemic halted, but virtual training was embarked upon. And 2022, we are hoping to focus on health profession students of medicine, nursing, and pharmacy. They are the actual healthcare providers of tomorrow, and there's need to really focus and concentrate on them in the spirit of interprofessional training. And the outcomes is that genetic counseling and testing will be carried out majorly among patients with breast cancer and their first-degree relatives. Participants appreciate the benefits of genetic counseling and testing according to our findings of various studies, although they express concerns about factors that could inhibit access to the services, such as cost and test-related anxiety, especially when the research component is over and they will have to pay. We had genetic results from the patients directly, and some of the findings include 8 in Lasut, who had 6 BRCA1, 2 BRCA2, and 4 in Luth, 4 BRCA1, and 3 ATM, and UCH 9 BRCA1, 8 BRCA2, 3 ATM, 4 PAP2, and 1 BRIP, and VUS 27, and the total BRCA1 19, BRCA2 10, ATM 6, PAP2 5, BRIP 1, and VUS 27. So this was at the time we had the first 100 patients, and we were informed of the risk of disclosing VUSs, especially because we do not have facilities for reclassification and categorization. So we stopped reporting VUSs after then. And the summary of all of this is assessments with family history, risk classification as average, moderate if it's familiar, and high if it's hereditary, and intervention standard prevention recommendations for average cases, and personalized prevention recommendation for moderate, and referral for genetic evaluation with personalized prevention recommendations for high risk classification. What nurses do in a nutshell is pedigrees, development and construction, which are valuable tools in determining the care needed for each patient and the patient's family members. Nurses, they perform verbal autopsy in family history taking for pedigree, particularly in our country where many people usually die after a brief illness and causes of death go undocumented. They obtain consent from patients for genetic testing. This is one of the training sessions where nurses were actually learning how to draw pedigree using paper and pencil. They obtain comprehensive family history, document the history information from the consultant and proband, and focus on details and cancer history, construct the 3 to 4 generation pedigree, identify questionable or incomplete information that will need further verification to assess cancer risk in the family, and identify sporadic familial and hereditary cancer patterns using the adapted genetic counseling album that I showed earlier, which is Yoruba version is this, and identifying the need for testing and obtaining consent, obtaining the sample, storing for shipments, arranging for shipments, obtaining results, and engaging in post-test counseling, and disclosure of results with ordering physician using the NCCN guideline, and applying ethical principles to counseling challenges. Eligibility and activities include providers who have basic genetic knowledge and who have demonstrated interest as much as possible with background in oncology, and patient and family counseling skill competencies. Activities include cancer risk counseling, risk assessment, genetic testing, capacity building, and so on and so forth. In a typical session, you have a pre-test consultation embedded within existing clinics in UCH, oncology units, the radiation oncology, radiation, surgical outpatient departments, as well as in various other designated centers. Patients are engaged in assessment of their concerns, motivations. Their patient and family cancer history are documented. Principles of hereditary and cancer genetics are explained, and informed consent is facilitated, and filling of a questionnaire, and then testing is initiated using color genomics hereditary cancer panel test. After the first 100, we migrated to first 400 patients, and in all of that, we had 319 processes, samples sent before COVID, and 299 were processed, 20 expired on our hands, and we had 22 resampling and 277 results obtained, of which 52 were of concerns, 225 were negative, VUS were 27, and 25 mutations were obtained. Result disclosure is about the last phase of the activity and support for the patients and family members. So description of the test that was done, a reminder, the interpretation of the meaning, and communicating implication of the genetic test results by the ordering physician and the nurse involved in the testing. Facilitating adaptation and coping with impact of results. In our environment, this is very key so that patients have correct interpretation of positive, of negative, and of VUS results, and personalized risk management recommendations, as well as possible resources are provided, and ethical, legal, and social issues that may arise are dealt with by both the nurse and the ordering physician, and patients are assisted with plan for communication of results and recommendations with at-risk family members of the